I'm sitting in the corner reading cartoons. He
like
has a good melanoma. Strong cat. It's stronger support.
I know it does. Like,
So, good morning to those joining us on Integrity. We are doing melanocytic lesions this morning. So, morning, Dan. Okay, everybody in? Dr. LeGroux, you want to start us
Oh,
out?
goodness. Wow. From this power, looks like there's a proliferation of potentially melanocytes here. There is some, it looks like some pleomorphism in the nuclei. It looks like they're on aqueous skin. And it seemed like they were getting somewhat smaller as we get deeper on this power. That is pretty big. So false. They're still bad at the bottom. Could be melanoma.
And what do you think about dispersion at the base?
That is a bad sign.
Dispersion is a bad sign?
I guess good from how you're answering that.
Dispersion is usually good.
Okay, this is
Dispersion
not
is good.
dispersing.
And
This
this
is
is not dispersing.
Therefore bad.
Therefore
Different
bad.
signs.
I knew that's exactly what you were trying to say. So you have something that is quite large. The cells are epithelioid. They run in fascicles. Now, do all the fascicles have a north-south orientation, or are they somewhat haphazard in their orientation? Haphazard in their orientation. And does that generally
That's
tend to
bad.
be good or less good? And then lack of dispersion at the base is worrisome, so it's a very large Spitz tumor, but with some worrisome features where it's not dispersing at the base. Has an architecture kind of like a blue nevus, where it's bulbous at the base. That in a blue nevus would be fine, and something with a spitzoid morphology is worrisome. And so you'd pursue MIB and other testing. Okay. Very good. Let's go ahead. Okay, Jessica.
So it looks like you have some nests that are cells, and there's appears to be sort of a mixed infiltrate there too.
Okay, tell me about the infiltrate.
It looks mainly lymphocytic, and it's very white-ganoid. Trying to figure out if it's a riot or the other one. Your cocktail party.
So are the lymphs all at the periphery of the lesion, or are they all through the lesion?
It looks like they're all through the lesion.
So all through the lesion is not riot police.
So it would be
So it
which
would
is
be
usually not
cocktail
as
party.
bad.
Which is, so that goes with what?
Cocktail party?
Yeah, cocktail party.
One of
the
them
riots.
was-
I'd rather be at a cocktail party than
So is that like
Yes.
a halo.
Like a halo nevus. Very good. So the Jen McNiff, great dermatopathologist, has been fond of saying that lymphocytes may be better at recognizing melanomas than pathologists are. So her point is just pay attention to the lymphocytes, see what they're telling you. So in this case, when you look from scan, you have a lymphoid infiltrate that's diffuse and kind of polka dot. It's not super dense. You can see every lymphocyte standing out from every other one, and they are organized as a diffuse band that goes all the way through the lesion and mingles with the entire lesion. That's the pattern of a halo nevus. And usually, you know, the easy way to do it would be to pay attention to the lymphocytes rather than struggling with the melanocytic nests. Okay.
So this is a broad melanocytic lesion.
So broad melanocytic, sun-damaged skin or not sun-damaged skin?
Not very sun-damaged skin.
Not very sun-damaged. What site do you think it might be? Looking at your corneum.
It's thick. I mean, I think maybe acral is how thick it is.
Maybe acral. I don't see any hair follicles. I see very thick corneum and a lucidum, so it may be acral skin. You as a clinician, what would prompt you to take such a big piece of someone's palm or sole?
Something I was worried was melanoma.
Yeah, so obviously there's some clinical concern given the breadth of the biopsy. The dermal part, how does the dermal part look to you?
It's not nesting very well. It looks like it's centered almost around blood vessels.
Yeah,
The large, like pleomorphic air cells in there as well as the vacuole.
so I'd say to my eye the dermal cells are fairly bland. I see some visible nucleoli, but they're pretty small. There is some evidence of dispersion. So the dermal has some, you noted that it was fairly tight around blood vessels and it's a little patchy. So some congenital features. The junctional part, though, let's talk about the junctional part.
There's some passageway scatter. Looks like higher up. They're spread. They're not like RNA reedy. They're kind of just confluent.
Yeah, there's effacement of the reedy, there's confluence, there are areas where non-nested melanocytes predominate over nests. The periodicity of the nests, is it very monotonous, or is it a more interesting Latin beat?
More of like the Latin.
It is a more interesting syncopated Latin beat. Great in music, not so good in melanocytic lesions, right? You want, benign nevi are very, very monotonous. Interesting Latin beats is not a good thing for a melanocytic lesion.
So would this be a rising in the congenital? Is that how you
So that's exactly what it looks like to me, is melanoma. And this part, these superficial nests, they could be bad. But I don't think this whole dermal thing is bad. And it's very frequent to have melanomas arising in pre-existing nevi. And that includes BRAF melanomas on the trunk as well as acral melanomas, lentigo maligna. Really common to see nevus in conjunction that it arose from. One of the hints is if the whole thing is just a compound nevus, the dermal part tends to be dead center. If, when you look at the whole lesion, if it's a melanoma arising in a nevus, the dermal part tends to be way off center somewhere. Now, depending on who did the biopsy, you may have centered your biopsy in a large lesion over a papule, which may give you the dermal part centered, as an artifact of going in and centering your biopsy around it. But if you look at the whole lesion, the pre-existing nevus tends to be off-center in a melanoma that arose in a pre-existing nevus. Look at the shapes of the nevi, or of the nests. Are these round to oval, or do they have little odd bumps, weird shapes to them? Exactly. So weird shaped nests. You look for evidence of adnexal extension. You look for confluence. There are some very bland appearing nests that may be part of the pre-existing nevus here as well. And then the areas that are very poorly nested at the junction. So I would favor probably MMIS arising in a nevus. One we'll put aside, see if there's anything salvageable there.
infiltration, nests on both sides.
Okay.
So I don't know if that's like a dense, like lymphocytic infiltrate in the.
So there is a lymphocytic infiltrate, and if you look at the lymphocytic infiltrate, is it evenly polka dot spaced throughout the entire lesion, or does it aggregate at the
It's more
base of the lesion?
targets the base of the lesion.
And when you look at the inflammatory cells, is it all lymphocytes, or are there other cells in here? What are
Plasma.
lots of plasma cells. Plasma cells in a melanocytic lesion, if it's in an axilla or the face, a Macarena site, it may just be anatomic site. But otherwise, plasma cells in the infiltrate of a melanocytic lesion is 99% melanoma if you're not on a Macarena site. So sheets of plasma cells in melanocytic, usually bad. Inflammatory cells at the periphery of the infiltrate, usually bad. What's going on in the dermis?
Is that is it collagen bundles?
Yeah, and are they normal, or are they big, thick, bubblegummy collagen bundles?
Big, thick, keloidal.
Keloidal. So this thing is sitting on top of not just a scar, but sitting on top of a keloid, suggesting there's been prior surgery here. So what do you think about recurrent nevus versus recurrent melanoma overlying this keloid?
Maybe the lymphocytic infiltrate would push you towards melanoma.
Yeah,
Or you
exactly.
wouldn't expect that with a-
Listen to the lymphocytes. They're talking to you. So are the plasma cells. They're telling you this is probably not good. And the melanocytic lesion itself may be difficult to interpret. Morning. The melanocytic lesion, because you're dealing with a recurrent lesion, you're going to have confluence. You're going to have all kinds of things that recurrent nevus gets that overlap with melanoma in the nest. So it may be more informative to ignore the nest for a moment and start paying attention to what the lymphocytes are telling you. The lymphocytes are forming a band at the periphery of the lesion, and there are lots of plasma cells in that band. That's pretty strong evidence that this is recurrent melanoma, not recurrent nevus. Very good.
Broad shave.
Okay, very good.
And not a lot going on in this. Looks like pretty centrally though. You've got some little nests forming. Tough to see the basal layer as well, but it does look like it might have a little bit increased density maybe of some melanocytes. Some
Okay.
confluence centrally.
And if you look over here, first off, your fibroblasts, what direction are they going?
They're running horizontal,
And how about all your blood vessels?
vertically.
And that usually means
Scar.
scar. So we again have a melanocytic lesion, not over a keloid in this case, but over a scar. And so we've got the same differential of recurrent nevus versus recurrent melanoma. Do you see any lymphoid infiltrate in this one?
Nope. Pretty
Nope.
sparse.
And is the thing large or small?
You can see all of it, so small.
Yeah. Well circumscribed or poorly circumscribed?
Well circumscribed.
Ends in a nest or doesn't end in a nest?
Ends in a nest.
So small, well circumscribed, ends in a nest, pretty much done at that point, right? So regardless of how confluent it may be in the center, it's probably recurrent nevus, not melanoma. The lymphs don't seem to mind it. It is small, well circumscribed, ends in a nest. Okay.
Okay. a lot of fibrosis. Also looks kind of keloidal.
Yeah, so we got another thing sitting on top of a keloid. So is this one likely to be recurrent nevus or melanoma?
So it looks relatively asymmetrical. I mean, there's kind of like patchy. I see that kind of one area at the right kind of border of the scar, and then there's another kind of collection. It looks like melanocytic.
So it is definitely a little asymmetrical. What's the size of the entire lesion?
Not huge. I mean, we can see it all.
Not huge, but not
Bigger than the
small
last one.
like the last
Yeah.
one either. Okay, and is there any lymphoid infiltrate?
I don't really tell very well from this power, to be honest with you, but yeah, a little bit.
Yeah, there is.
Blue stuff down there.
So, the first one we had, the lymphocytes were screaming melanoma. They were at the periphery. There were plasma cells. The second one we had no lymphoid infiltrate. It was small, well circumscribed, ended in nests. This one is a little broader. It has a little lymphoid infiltrate. So what are you going to do?
I think it needs to be. I'd probably look at it under a higher power.
But much more important than looking at what's on this piece of glass is
the last thing.
exactly, that's where the answer lies, not in this specimen at all, but in the prior specimen. Pull the prior biopsy. If someone else did it, get a hold of it, because that's where your answer lies for this one. Some of these are a little dirty. Okay, Adam.
Okay. So, it's like we have almost the entirety of the lesion, probably the entirety of the lesion here, and you have a compound proliferation with a lot of pigment in melanophages and elsewhere.
Okay.
There's nests, some of them large at the junction. As you go deeper, things tend to disperse a little bit. I see individual dispersion. Some of them do seem to be collecting around adnexa blood vessels.
And what's the pattern in the dermis here?
A pattern of what, sir? I'm
The
sorry.
melanocytes?
You referring to them being a little spindly in shape?
Yeah,
or-
you got lots of dendritic melanocytes
Right.
in the dermis, right?
Yeah.
So you have, in fact, your dermal component has a lot of dendritic
Yeah.
melanocytes.
So I was thinking about a blue nevus as a possibility, but up top there's some areas that have almost spitzoid kind of features. So
Yeah, so the top,
It's a combined nevus.
it's certainly an epithelioid, so you're thinking of a combined nevus. So now I go to the edges. It doesn't really end in a nest the way I might have preferred that it did. It is reasonably well circumscribed. Now I'm going to go to the base, and it doesn't disperse at the base, but at the base is the blue nevus component. Are they supposed to disperse at the base?
not often.
They're not. Blue nevi aren't supposed to disperse, so that's not going to help me. It doesn't disperse at the base, but it's a combined nevus, and that's the blue component. So the things that are reassuring about this, it's combined with a blue nevus. It's very, very rare for melanoma to occur in a combined nevus with a blue component. So the fact that there's blue nevus in there, 99% that this is going to be a benign.
Is it more
Lesion.
common for that to happen with like cellular blue nevi than common blue nevi? like just melanomas arising in that?
Oh, melanoma arising. So melanoma rarely arises in combined
Okay.
nevi. When it arises in a blue, you're absolutely correct that it tends to arise in cellular blue. Cellular blues occur where?
They're not on the scalp.
They are
They're scalp.
backside and scalp.
Backside.
So cellular blue, common blues are common face and dorsum of hand or foot. Cellular blue is on your backside and your scalp. Almost all of the melanomas in cellular blues are on the scalp. Very, very rare to get melanoma arising in a cellular blue on your backside. But what you do see, a dime a dozen in those, is broad areas of necrosis and edema. Why? Because it's the size of a walnut and you sit on it all day. Right? So ischemic necrosis is very, very common in large cellular blues on the backside and commonly gets overcalled. Whereas, so it's important to remember that that's a site where they almost never become malignant, whereas on the scalp, where you don't see the ischemic necrosis, that's where cellular blues are more likely to become malignant. Okay. And it may just be the sun exposure plays a part in it, but the ones that look scary are commonly the ones from the backside, and it's usually areas of ischemic necrosis. There you go. Let's see. Okay.
Right, it's a nice broad shape biopsy of skin showing most of the actions in the dermis, but at the DE junction we do have some small nests of melanocytes, some pigmented keratinocytes. But dropping down, the dermal component seems to be these mostly east-west oriented fascicles of cells.
And the junctional component, arch involvement or mainly tips and sides?
Mainly tips and sides, so I'm not overly worried about this lesion at this point. This could be this could be components of potentially blue nevus as well, sort of more of a cellular spindle blue nevus.
Yeah, I mean the dermal component could be all sorts of things. The junctional component tends to be aggregated at tips and sides of Reedy, which is usually a very reassuring feature. We've got the image on the screen seems to be very pixelated. Any thoughts on what we might do to improve that?
What's the ISO setting? I've noticed sometimes that makes ISO 200. Try it up higher. No, that makes it worse.
Tom, it looks fine to me over here.
Okay.
Looks fine where you're sitting?
Yeah.
Okay, we'll just continue. It doesn't, like if you tried to take photo mics of that, they'd be bad. Your lymphocytes would be square instead of round because it's going into pixels. So, okay. Okay, so this might be the best place to start.
Yes, it's got a broad shave here.
So broad shave. Put yourself in the shoes of the clinician. Are they worried or not worried?
Well, they took it off, so
And how much did they take off?
a lot.
They took off a lot. Exactly. They're worried.
Yeah,
Okay.
it's kind of like a nodular area right here in the dermis.
Yeah.
It's like really circumscribed to here.
So your nodular area, first off, when you look at your junction, most of this is bulbous, reedy with larger nuclei, it's just let it go,
Okay.
right?
Yeah.
So there's probably a big broad thing on a sun-damaged face, and they were worried about Lentigo maligna. And we got miles of just solar Lentigo. Doesn't look bad at all, really. Over here on this side, though, you've lost your reedy pattern. So there is real asymmetry of the epidermis. So you'd probably want to get some kind of SOX10 melanase, something to get an assessment of the melanocytic density in there. And then let's focus on this in the middle. You think that's an incidental nevus, or you think that's bad? And why? Let's go down to scan.
At this power, I just thought it's just a dermal nevus.
I mean, it's certainly
It is.
very well circumscribed, right? Okay, look at the base.
But it doesn't really disperse.
Is it dispersing?
Not really. It's
No,
simply-
that's what you're getting at.
Yeah.
Doesn't disperse at all, right?
Yeah.
Now we're going to look at maturation, cells at the top versus cells at the bottom. I'm not sure it's maturing or dispersing. Okay, nevoid melanoma. So, just general advice. The ones that you know are hard are not the ones to worry about, because you're going to send this off for a second opinion. The ones to worry about are the nevoid lesions that you never saw coming.
Okay.
The ones that, busy day, nevus, next case, next, nevus. Careful. Lack of maturation, lack of dispersion are features of nevoid melanoma. And that would cue you then to look a little bit higher. So we're going to look higher, and we're going to look first off for mitotic figures, right? See if we can pull that into a little better. Not seeing a whole lot in the way of mitoses. We do have visible nucleoli, some of which are red. So if you have a Spitz, red nuclei don't mean anything. If you have something that is not a Spitz, red nuclei would be highly, highly unusual. I'm sorry, nucleoli, sorry.
That's what I thought you were saying.
You knew what I meant. So red nucleoli in the setting of something that is not a Spitz is highly unusual. Look at the nucleoli here. Is it round, or is it like a starfish with little arms hanging off of the nucleolus?
I'm going to say it's starfish. I can't really see a nice
Okay, we can go
flush out.
even a little higher in there and try to get a better look at some of these. But you have some very irregular nucleoli. And the melanocytes, are they round,
No, they're
angulated with nuclear molding? So angulated nuclei, nuclear molding, bizarre shaped nucleoli that aren't round, visible nucleoli that are red. This is melanoma.
So Dr. Elson, in this particular biopsy, would you try to give any indication to the clinician that the majority of the lesion is so small and in the middle of the, you know what I mean? Because like they took a huge biopsy, but really, in terms of their surgical margin or whatever they decide to do.
Well, so that's an excellent point that you brought up. So the clinician is someone who knows what they're doing. And so they looked at, or they took a piece of what was probably the darkest portion of the lesion. They probably went for something that had a visible papule, where they were worried about invasive melanoma. So what we saw on the one side was large cell acanthoma lentigo. What we saw on the other side was effacement of the reedy pattern. That's probably part of the in situ melanoma. When you're biopsying for suspected lentigo maligna, what's your eye drawn to? Usually the darkest,
Color,
the darkest portion of the lesion. I guarantee that is the part with the greatest pigment incontinence. not necessarily the part that's most diagnostic for melanoma, just the part with the greatest pigment incontinence. What percentage of lentigo maligna have solar lentigo in them?
Very high.
Yeah, almost half. So, and that can be the area with the greatest pigment incontinence. Could be the pigmented AK, the solar lentigo. So, small samples out of lentigo maligna, as bad as 80% false negative rate. Going for just the darkest area with a 4 millimeter punch, as bad as 80% false negative. Which is why we tend to take broad biopsies. That what we looked at there, it's not as thin as we often try to do. I mean, we're often trying to do thin so we don't scar the patient. With Jean Bologna, she always tells her residents, Jean does pigmented lesions and she's Italian, so she tells her residents, I want your shave biopsies for lentigo maligna to look like properly cut prosciutto, right? It should be paper thin horizontal slices. Because you're not trying to disfigure people, but you're trying to give the pathologist a piece that will be diagnostic and not risk that 80% false negative risk of a small biopsy out of a lentigo maligna. Will you ever transect an invasive component? Sure you will. But the much greater risk is missing the diagnosis of melanoma. And when you go back, I mean, you'll excise it, and you took such a paper-thin thing, it's not going to affect your assessment of depth. It's going to be fine. The other way to approach it is to take little superficial shaves, multiple, of every color in the lesion, put them all in the same bottle. That's normally what I do. Because you don't care what part of that is lentigo maligna. You want to know, is there lentigo maligna in there? Doing that also gives you an assessment of what else you're going to see in that lesion. So you can already, if you're going to do it by Mohs, you already know you've got pigmented AK and lentigo all mixed in with the melanoma, and the melanoma goes all around it. Means when you hit an area of pigmented AK, you're not necessarily at the periphery. Yeah, you got to be very careful of your contiguous growth pattern. Okay.
So it's like you have like a carbon tattoo or kind of foreign
Very good.
body in
That's
there.
exactly what it is. So pigmented lesion that is not melanocytic, that is a tattoo. It's all down perivascular within melanophages, and it's black. Melanomas can appear black clinically, but the pigment is always brown microscopically. This is black pigment, so you're absolutely right. That's a carbon tattoo. Good.
So I wonder if we're in mucosa. There's also
You are correctly, and you weren't really wondering. You knew very well we were on mucosa. You were just being diplomatic. So. And what mucosa?
I think that's perhaps their skeletal.
Yeah, skeletal muscle. So what mucosa will have skeletal muscle?
Oral mucosa or
Well, exactly.
oral
So oral. Other mucosal surfaces like genital, you have smooth muscle but not striated muscle. So striated muscle on a mucosal surface puts you oral mucosa. And so there is a pigmented lesion, presumably in the mouth. So you'd always look in your dermis for things like amalgam tattoo. But here, what do you see?
Well, there's what appears to be melanocytes with dark and irregular nuclei.
Yeah, so they're kind of angulated, dark melanocytes. Do they give you a nice warm fuzzy feeling?
Not really.
Not really. And are they aggregated at the tips and sides of rete, or do they just keep going up into the arches?
They keep going.
Yeah, remember melanoma is your arch enemy, so arch involvement, not good. And even though this really doesn't look confluent anywhere, the density is no different at the tips of the reedy versus up in the arches.
Right.
That's a bad thing. The cells are angulated and hyperchromatic. On any lentiginous melanoma site, that would be a bad thing. So acromucosal, that would be a bad thing. And if we went on higher power, you'd see that the dendrites themselves are very asymmetrical, with big fat dendrites and skinny dendrites. And you see one big fat one going off in one direction, and it's not symmetry of the dendrites of the melanocyte. That's also worrisome. So that one would be an in situ melanoma. Let's see what we got here. Let's see, we did once around the scope, so we should give the people not at the scope a chance. And we still have we have multiple heads, 3, 4, 5, 6. I see 6 heads at the scope, so everyone is welcome to join in if you want. You probably need where's the little hex wrench tool on this guy?
It's
Right here on the side. If you need to reorient any of those.
Ask and you shall receive.
There you go. If anyone needs the hex wrench, we got it right here. We'll pass it around to you.
Here are 2 chairs.
like
2 thanks.
Tetris with a leg.
2 chairs, 2 heads. Look at that.
Actually, are you okay there, or do you want to sit here and
Built a baby bump.
Well, I could sit at the slope. I couldn't lean in far
Oh, really?
enough. Yeah.
Okay, everyone good? And, we're very informal, so, when you get here, don't
And our
Don't be
confunders
shy.
are medical students.
why? I understand. So, when you get here, just join in and grab your place at the scope and see where there are seats. Okay, so Ashley, what do you think?
Sure. I'm seeing in the epidermis there's a basement and then there's a melanocytic lesion. It's not really well nested. There's a basement of the ready ridges. It's ill defined, not ending in a nest. And then in the dermis, there looks like scar and largely loss of adnexal structures. I'd be worried about a recurrent lesion of some sort.
Yep, absolutely. So you got scar, you can see the vertical vessels, and so you phrased it very well. Recurrent lesion. Now you want to know, is this recurrent nevus or recurrent melanoma? It would be very helpful to see the prior lesion. This one is not that big, so it's more likely, common things being common, it's more likely recurrent nevus. So, because we're never going to find our place again, James, you're going to just...
This looks pretty evil from this power.
Looks
I'm pretty worried about malignant melanoma.
So,
And there's like a bunch of jumbled, confluent, evil-looking melanocytes.
so jumbled, confluent, the nests are not similar in size and shape. They're not equidistant from one another. You have horizontally oriented sausage-like nests, areas where non-nested melanocytes predominate over nests, red flat bottom fibrosis pushing the solar elastosis down, adnexal extension. I rest my case. You are correct.
Beat by 3 level right there.
That is malignant melanoma.
So it looks like they're a pretty big biopsy. Looks like there's a little nest right there.
And pretty big meaning broad or meaning deep?
Deep.
Yeah.
Looks like there's maybe some, there's a scar. There's spinal cells in the dermis.
Yeah. That's probably all scar.
Okay. And so there's a scar then, and then it looks like there's a recurrent lesion above that.
And it tends to be very large, or you think it's very small?
It looks pretty small.
Yeah, so what do you think?
Maybe a recurrent nevus.
Yeah, and when you have a patient who comes back who's had a lesion saucerized, and then they come back with a jet black dot in the scar that they're worried about, what do you do? Yeah, and how do you biopsy it? Punch it out. Exactly. So, how often will a dermatologist reach for a punch when dealing with a melanocytic lesion? Rarely. I mean, the two ways. One is you're trying to take out a mole that you know is a benign mole, and you can stuff the whole thing into a punch, right? So that would be one time you would do it. But more commonly, it's a recurrent nevus where you've got a little focal, deep thing. It came from adnexal involvement of the nevus and recurred from a hair follicle. If you shave it, it's a good chance it's just going to come back again. So you're likely to do a little punch there. So that's exactly what you're looking at. Small circumscribed lesion sitting over a scar in a punch.
A very brisk lichenoid infiltrate around
So
it.
a brisk infiltrate in a large lesion or a small lesion?
It looks like a smaller lesion.
Smaller
Looks like
lesion,
it
and
punched
the
it out.
infiltrate itself is all at the periphery.
No, this is mixed in, so I'm guessing this is more of our cocktail party.
And so if you have clinically a patient who presents with a halo, and there's a papule in the middle of the halo, you would sometimes punch out the papule, right? Which is exactly what you got here.
Looks like an excision or a broad deep shave. So.
Yeah, so it does look like a big excision, right? Of what kind of skin?
Mucosal or scalp.
So, quite possibly scalp. I mean, they're big terminal hair follicles. Could be beard area because these are kind of stout, fat hairs. So I would think maybe more, with all the sebaceous in the beard area, maybe more beard than scalp.
Then there's a dermal component of this. They're not very well circumscribed. I don't see much of a epidermal or junctional component. Maybe a little bit. Right there, yeah.
And is the junctional component well nested or poorly nested?
Poorly nested, it's going like the sides of the reedy.
So poorly nested up the sides into the arches. So, the junctional component doesn't look good. What's this intervening component?
So that.
With the horizontally oriented fibroblasts and the vertically oriented vessels. Scar. So you've got a junctional component that's confluent and involves arches and up the sides of the reedy. And then you got a scar, and then below that,
So it's kind of. So the ones that don't look like they're maturing, they're very small at the base as the top
So that'd be the question. You know, you're going to look higher at this to see, is there maturation? Looks like there may be some dispersion here. So if when you look at higher power, this just looks like a nevus, then your answer is probably recurrent nevus, right? And it was probably read as something worrisome, which is why it's being re-excised, but it's probably just recurrent nevus if this part is benign. If this at higher power is worrisome, then it could be recurrent melanoma. But probably with this dispersing at the base and that zonal, something that looks bad at the junction, but then a scar and then a bland dermal thing, it's probably just recurrent nevus. And it may well, remember re-excisions, if the pathologist expressed some concern, they're going to go back and you're going to get a big re-excision specimen, regardless of site. And remember, that is commonly places like scalp, breast, groin, where they always appear atypical. And as a pathologist, remember, those are the places nevi always look worse. And remember the consequences of saying re-excise. Because kid scalp, it's usually a centimeter and a half to begin with. And now you're telling them to take a margin around that in a kid's scalp. That is a big excision in a kid's scalp. Breast, genitalia, people tend to be protective of those sites. So,
Dr. Elson, I have a question.
yes.
Would it be also valid to call it residual as opposed to recurrent?
Sure. Yeah, I mean, so if you do my dot recurrent, it comes out recurrent parentheses persistent nevus. So it's kind of semantic, but there are people who get very huffy that it's not recurrent, it's persistent. It's both names are there. So whatever you like, it's there. Okay.
There's a little shape there. Looks like it's acral skin.
Yep.
And then pretty much involving the whole sample, you have this nesting. Seems to be mostly located at the tips.
So
sides.
mainly located at the tips and sides.
Right, but there are a couple areas where it does seem to creep over.
Yeah, and how about your reedy pattern?
Reading pattern seems effaced in areas.
So where do you think you are?
I originally thought maybe like palm or sole.
Yeah, I mean, you're on an acral site, right? So here your reedy look normal. Here they're starting to become confluent, the reedy themselves. That tells you that you're dealing with a whorl or a loop in the dermatoglyphs, so that there's no way to cut this where you're not oblique in some parts, because the dermatoglyphs are your reedy ridge pattern. That's what makes fingerprints, that's your reedy ridge pattern. And if it's a whorl or a loop, you're going to get areas of confluence, and then your nests are going to look different in size and shape, but so do your reedy, right? So one of the things to do on acral sites is abandon the lesion itself and go to the corneum. And in the corneum, you're going to say you have columns of pigment. Are those columns of pigment evenly spaced or non-evenly spaced? Do they tend to be nice, tight columns or all spread out? And the best you can tell, do they correspond more to the apices, the ridges, or more to the little furrow?
I believe the second choice.
The second choice. And of the two, ridges are risky, furrows are fine, right? So if they are fairly evenly spaced, well-defined, tight columns of pigment in the furrows, It's a nevus. And sometimes, because of the oblique pattern of the dermatoglyphs, the nevus itself looks really scary. That nesting pattern looks very irregular. Go back to the corneum. If it's nice, tight columns of pigment that are all corresponding to the furrows, it's just a nevus. And remember, again, the implications of saying re-excise everything on palms and soles. How happy are your patients with the xylocaine injection on the palm or the sole? It hurts. And now it's a big excision, and they're going to have to walk on it. And it's going to dehisce, and it's going to get infected. And when they take a shower or bath, they stand on that wound, and you're going to get serratia in there. And I mean, you're just a setup for every problem you could possibly have on a palm or a sole. So as a pathologist, remember there's a clinician on the other side, and he's or she has an idea in their head how worried they really were about this. And now they've just gone back, they've done a big excision they didn't want to do that makes the patient unhappy, it dehisces, it's secondarily infected, and in the back of their mind they know this one wasn't that bad. So just be careful of over-calling on those special sites where they always look a little funny, and it's often the reading pattern that's making them look funny. Just the dermatoglyph pattern.
Okay. We have a large melanocytic dermal proliferation here with kind of nested cells and kind of this red stromal kind of interspersed through it. So, I mean, the first thing I thought of was like a blue nevus.
So you think of a blue nevus. Do blue nevi do that kind of nesting?
No, the nesting is...
And do blue nevi get necrosis en masse?
No, not unless...
The only place they do is backside. So, blue nevus, a cellular blue on the backside, I mean, that just could be ischemic necrosis. So you want to know site. This is heavily sun-damaged skin. So if it were the backside, it would be an interesting history to include use of mirrors, right? Or tanning bed. But pretty dry. I mean, that would be a serious tanning bed habit to have your backside that solar damaged, right? So more likely we're dealing with sun-exposed skin, an area where that would not likely represent ischemic necrosis. So I'm worried about a big nodular melanoma. In terms of symmetry, nodular melanomas are very symmetrical. Remember, there is nothing more symmetrical than a met, right? It is a sphere, symmetrical in all dimensions. And nodular melanomas are very similar in their growth pattern. They can end in a nest. But when you look across, first off, ignore the melanocytic lesion. Just look at your epidermis. Is your epidermis symmetrical from left to right? Or does your epidermis change dramatically with acanthosis and effacement? Just your epidermis itself is very asymmetrical from one side to the other. You have big sheets of confluence, some of which have central comedone type necrosis. All of those things that scan tell you that this is melanoma. Okay. Remember, we just read them. We have no control over what they sent us.
This is a smaller sample. It looks like there's no epidermis on every piece. It looks like we're dealing with a pigmented lesion. They look a little bit spindled. Have pigment incontinence.
I'm keeping going up and down for a reason. Is that pigment refractile or non-refractile? Does it light up as we go up and down? And if you ever have a question about that, flip your condenser down. Okay, now look, does it light up? Yeah. So, increasing your refractility by putting the condenser down is a really good way to tell iron from melanin. Melanin would not light up like that. So, tells you that's not melanin. The other thing is the chunks are too big. They've got a little bit of a greenish yellow hue, shades of bilirubin, biliverdin type shades. All of that tells you it's an iron pigment. Could be hemosiderin. In this case, it's actually a Moncell's tattoo at a prior biopsy site. But the pigment itself, because they can look very scary. You can go down the road where I see spindle and epithelioid cells and vesicular nuclei and big nucleoli. Well, they're histiocytes. So the pigment itself can be really helpful, and just that trick of putting your condenser down can be really helpful in terms of identifying the pigment. Okay, I'm trying to...
I guess we'll just sit here.
Trying to select for a few things we need to talk about here. Okay. So, what do you think?
All right, so we have a punch. You have, again, almost kind of got the entire lesion. It's a compound proliferation with some pigment in the dermis as well. I'm just trying to look at kind of the architecture of them to see if some of them are a little spindly, almost like a spitzoid.
Yeah, so you have spindle and epithelioid cells, and the theques are haphazard orientation or tend to be north-south?
North-south.
North-south, which is very Spitz-like. I see a little bit of involvement in the arches. So now there's the question, do I need to be worried? There's a question, are these just nests in adnexa, or is that adnexal extension? It is relatively small. It's well circumscribed. It ends in a nest. Does it disperse at the base?
Yeah.
Yeah, it does disperse at the base, which blues don't, but Spitz do. And then it has hyperkeratosis, acanthosis, pseudoepitheliomatous hyperplasia. What are these dull pink collections of basement membrane material? Caminobodies. So what is it?
Spitz.
It's a Spitz. It's small, it's well circumscribed, it disperses. Spitzoid melanoma essentially never disperses. The lack of dispersion at the base is probably your best single feature for spitzoid melanoma. Whereas this disperses at the base, it's small, well circumscribed, ends in a nest, has caminobodies. It's going to be fine.
Alright, so in this lesion it looks like you have a large dermal proliferation of spindle cells, and you have these inflammatory aggregates like nodules at the base.
So a dermal spindle cell proliferation with lymphoid aggregates.
Spindle cell melanoma.
Yeah, until proven otherwise. So what do you want for a stain?
You can do SOX10 or S100.
Yeah, those are the two, and they're probably equivalent. There was one paper which the editor should never have allowed. The title which was published was SOX10 is superior to S100 in detection of desmoplastic melanoma. It was 11 versus 10.
Ooh, tie goes to the runner.
Exactly. I mean, that's not statistical superiority. And the problem is when you search, if you do a PubMed search, you pull up a title that says SOX10 is superior to S100. They're both fine. Both do anything neural crest. So neither one is specific for melanocytes. Both do anything neural crest. So they do schwannoma, they do neurofibroma. They're just broad neural crest markers that are non-specific but highly sensitive, including in spindled lesions.
Is there a big price difference?
Eh.
No.
Yeah, not really. Neither one is that finicky a stain. Both do nuclear, although S100 also does cytoplasm. So, whichever is fine. Okay. And that's it. We're out of time.